I'm going to introduce Dr. Rodney Breau first. Rodney is a surgical oncologist and assistant professor of urology at the University of Ottawa, and he is an associate scientist at Ottawa Hospital Research Institute. He attended the medical school at Dalhousie University and did his urology residence at the University of Ottawa. He then completed his Urologic, Oncology, and Robotic Surgery Fellowship at the Mayo Clinic and received a Master of Science in Clinical and Translational Research from the Mayo School of Graduate Medical Education. Is that correct? That's a tongue twister. He's also a founding member of the International Evidence-Based Urology Group and serves on the American Urological Association Steering Committee for Evidence-Based Reviews in Urology. Dr. Breau's research interests include population-based observational studies and clinical trials, and he is a member of the Society of Urologic Oncology and has been recognized nationally and internationally for research contributions in prostate, kidney, and bladder cancer. So thank you for joining us tonight. Dr. Breau.
Yeah, okay. Well, thank you for inviting me, and I just wanted to thank Mary for sharing her story. I think that we have many patients that we care for, Neil and I, every day with very similar stories and at various stages along their journey. And we feel very honored to be able to be a part of that journey and to do the best we can to make your life and the experience as good as it possibly can be. I think in that way, both Neil and I and the fantastic group we do have here in Ottawa, we're very fortunate to have that for our patients with kidney cancer. We share the same goals as Kidney Cancer Canada, so it's our honor to help out tonight and speak here. We want to be fairly vague in terms of what the objectives were of this talk, so I encourage anyone, if you would like, feel free to stop me through this. It will be fairly general. You may have some questions, and I think both Neil and I would be happy to field those later, or if you want to interrupt me during the talk, please feel free. I do have a couple of objectives. One is I'd like to present a clinical case. I didn't know that Mary would be speaking because that was really a fantastic example of sort of treatments that can be received. Especially explaining the surgery that Dr. Caggianos did. But I'll cover a range of things because obviously the type of surgery or the type of treatment will be very individualized based on your situation or your family member's situation. But I would like to share one of the stories from one of my patients. So she was a 35-year-old woman, and this is a fairly classic thing that we see as urologists, uro-oncologists. She had abdominal pain or some sort of symptom that was really not related to their cancer or anything at all. Otherwise very healthy. She had an ultrasound that was ordered by her family doctor, very similar to Mary's story, and it suggested that there was a left kidney tumor on that, and therefore a referral was made to me for further assessment. So I did see her, and based on the ultrasound which suggested a tumor, we got a CT scan or a CAT scan. This is one of the images, so I'm sure many of you are not familiar with how to read these, but these are like cross-sectional images of your abdomen. And so the right-hand side is actually on the left side of your screen. This is the right kidney, which sort of shows up like a C. It's quite bright, but on the other side, it looks a bit different. And in fact, this tumor is about 10 centimeter or so tumor in the left kidney, which very much looks like a kidney cancer. So I want to come back to that case at the end and give you a bit of story, but before we go into sort of what happened to her, I'd like to explain a little bit about the range of situations that people can be in and give a bit of information about kidney tumors and obviously kidney cancer. So what is the kidney? And I think that's in some ways, many of you may be quite knowledgeable on this, but maybe some of you aren't. So we have two kidneys usually, although some of us are born with one. The kidney filters the blood, and it filters a lot of the toxins and extra fluid that we have, and generates urine. The kidney also has other functions, many hormonal functions related to blood pressure, production of red blood cells, and other things like that. So the kidneys are obviously very important organs for us. Kidney tumors, in fact, are extremely common, but not all of these kidney tumors are cancer. And sometimes someone will be referred with a kidney tumor, but we're not sure if it's cancer or not, and there's various ways that we can differentiate them. Now, I have a few pictures here. I don't think they're overly gross, but if you're a bit squeamish, you may just want to be careful. So this is a picture of an actual kidney, and this has a kidney tumor, or several kidney tumors on it, but these are non-cancerous tumors. These are cysts, and many people will have cysts. In fact, especially as you age, it's very common to develop these benign cysts. And we don't need to do anything about these. We don't need to treat them at all, and they're like I said, they're very common. There are also some tumors that are true tumors, but they're not cancerous tumor. This is an example of one that I removed it was fairly large, but it was a benign, something called an oncocytoma. So it's a tumor that can grow quite large, but it doesn't behave like a cancer because it doesn't spread in other parts of the body, which is obviously more concerning. Sometimes these benign tumors also need to be treated, and usually if they're treated with surgery. This, of course, is an example of kidney cancer, so renal cell carcinoma, and there's various forms of kidney cancer, but renal cell carcinoma is the most common. And as you can see, this is very similar to the CT scan I showed, where there's a tumor involving a good portion of the kidney, where there's a small portion of normal kidney here at the top. So how common are these kidney tumors? Well, tumors are quite common, and cancers are quite common as well. So 5,500 of us in Canada will be diagnosed with kidney cancer in 2013. And that translates in the Ottawa area to about 170 patients just in our city alone that will be diagnosed with kidney cancer. Because we see a lot of patients, or a lot of people from outside of Ottawa, the numbers that we see here at the Ottawa Hospital is actually much more than that. And unfortunately, many people will die of kidney cancer as well. So what we have seen over the years is that the actual number of patients who are diagnosed with kidney cancer is increasing. And why is that? Well, when we see increases in any cancer, we think, well, maybe it's because more tumors are forming. But we know from many other cancers as well, it's because we detect more cancers. So the story that I gave at the beginning, where somebody has an ultrasound for some other reason, is in fact quite a common one. And on that CT scan or MRI or ultrasound, a tumor is found in their kidney. And after 1995, the use of CT scan has grown really exponentially. And the number of these tumors that we are detecting are growing very rapidly as well. It is starting to level off. This is data out of the United States, but it's very similar in Canada. Thankfully, what we have seen, we haven't seen a rise in deaths from kidney cancer. For a while, we were seeing an increase in not only the number of tumors that we were detecting, but also more commonly people were dying. And so this is not what we want to see, because hopefully our treatments are getting better, so people are living longer and not dying as frequently. Thankfully, since about the mid-1990s, it's leveling off and actually decreasing, which is a really good thing. So people will commonly ask me, and maybe many of you have asked yourselves, what did I do to cause this? And really, kidney cancer is very different than many other cancers that we see, lung cancer, bladder cancer. There's no real one thing that tends to be a cause for kidney cancer. Many people with extremely active, healthy lifestyles, like we just heard, will develop these tumors, unfortunately. There are certain things, though, that do increase the risk of developing cancers, and we're not entirely sure why. We have some ideas why. Smoking, obesity, high blood pressure, male gender, and also exposure to some compounds and chemicals and dyes can increase that risk for cancer, although typically we don't think of it as being the cause of cancer. On the bottom here I have genetic syndromes, and there's no question that there is a minority of patients who have gene defects or genetic syndromes, genetic diseases that predisposes them to developing kidney tumors. In some of these diseases, 100% of patients will develop kidney tumors. And so they are clearly a major risk factor if somebody, or if that runs in your family. Von Hippel-Lindau disease, for example, would be a classic example of that. As I said, most kidney tumors are totally asymptomatic, meaning people have no idea. They would have no idea that there was anything wrong with them at all. Years ago, before I was practicing, it was much more common that people would present quite late or at very late stages in their disease. And the classic symptoms that would be found would be blood in the urine, pain in the side or flank, and you can actually feel a lump. Thankfully, that's only about 10% of the patients that see us now that have that sort of classic symptoms of kidney cancer. Any questions before I move on? Fairly clear to people? Okay. Kidney cancer is sometimes thought of as the internist tumor, or at least it was for many years. Sometimes when people have symptoms that just can't really be explained, rapid weight loss, night sweats, fever, high blood pressure, rashes, sort of unusual things or weird constellation of symptoms, physicians will think of kidney cancer, because kidney cancer also tends to produce chemicals that can cause all kinds of strange things to occur in somebody's body. And pretty much you name it, it can occur in people who have kidney cancer. And if we're able to treat these tumors before they leave the kidney, then often with removal of the kidney or removal of the tumor, all of these constellation of symptoms will go away. So kidney cancer is a very interesting one for doctors, because there's a lot of things that occur with it that are different than many of the cancers that we treat. So for the management of kidney cancer, Neil's going to talk a little bit later about advanced kidney cancer, meaning when the kidney cancer has spread to other parts of the body. Thankfully, many of these tumors are identified well before they have left, and so people have options with curative intent. So surgery really is the mainstay of treatment, because unlike some other tumors that we treat, chemotherapy and radiation is not frequently curative. And like I said, if we can detect that tumor while it's still in the kidney, clearly the goal is to get rid of it forever. And so surgery is the vast majority of treatments that people will receive. So when I speak about localized tumors, what I mean is that it's not gone to other parts of the body. And the classic way that these things would be treated would be to remove the whole kidney. So this would be an example of something that probably wouldn't happen very often these days, where the whole kidney is removed and the tumor that's in the kidney is also removed. And that's called a total nephrectomy or radical nephrectomy, you may have heard about. In some cases you have to do that, but in some cases you don't. And in those situations where radical nephrectomy may not be required, we can just actually remove that tumor from the kidney and preserve much of the remaining tumor. And we call that a partial nephrectomy or nephron-sparing surgery that some of you may have heard about. And obviously that has a lot of inherent benefits. It's usually good if we can keep somebody's kidney, and obviously if we can reduce the extent of surgery we need to do. Does anybody have any questions about that? I won't go into too much detail. Yes?
Is there a size or location that determines?
Yeah, good question. So there's no specific cutoff for size or location. It really depends on a whole bunch of factors. So if the other kidney is very normal, then obviously removing one kidney with a tumor in it is is often times a good thing. But if you have some problems with your kidney to begin with, or if the tumor is very large and there's not much kidney to save, or if it's in a location that just would really increase your risk of complications, then in those cases, removal of the kidney is probably the best thing to do. So it's a whole bunch of factors, and that really has to be taken on a very individual basis, because while it may seem that partial nephrectomy is simpler, it's actually much more complex. This radical nephrectomy is actually an easier operation on the patient and the surgeon than a partial nephrectomy.
I just had mine 2 weeks ago.
There you go. So this is a little bit more of a gory, so you may want to close your eyes. But this is an example of a surgery that was done. So there was a tumor about 3 centimeters in size. So instead of removing that whole tumor, the whole kidney, I was able to just remove that one spot from the kidney and do a partial nephrectomy. And then there's a little bit of a divot in the kidney that needs to be repaired. And just with sutures and things, we're able to repair that and put a little bit of patches in there. And so really 95% of that kidney function is preserved by doing the partial nephrectomy. So when we can do it and it's safe for the patient, we like to do it, obviously. But as I said, in some situations, this would be an example, putting somebody through a very complex surgery with a lot of potential risks to only preserve a little bit of the kidney doesn't make a lot of sense. And so in that case, situation like this, unless that was the only kidney that the person had, we would typically remove the whole kidney. Mary mentioned earlier, in some of these larger tumors, especially when there's extension of the tumor, sometimes up to the heart or around the liver, or lymph nodes are involved, we'll typically do an incision in the front that can be under the rib cage or in the middle. In some situations, we can do an incision near the ribs or on the side. And in other situations, we would do this laparoscopically, where we put tiny telescopes and instruments in to do the surgeries. It really, like partial versus radical nephrectomy, the decision to do these different methods of surgery really depend on a whole bunch of things, including the patient, the tumor factors, but in all cases, we try to do the thing that's best for the patient, whether it be laparoscopic or open meaning a larger incision, and whether it's removal of the whole kidney or just part of the kidney. Here's a typical example where we make small incisions. This dotted line is on the rib cage, so the person's on their side. And we put a camera in through one of these and instruments in that way and try to do it in that method. The main reasons for doing that is just to decrease the recovery time. And this is kind of what it looks like in the camera. So here's a kidney, and this is a fairly large vein that drains the blood from the kidney, and back here is the major blood vessel or the artery that serves the kidney. And then afterwards, another benefit is decreased scars and things like that. So I did want to touch upon just very briefly about other forms of treatment which you may have heard about, especially in some smaller tumors, which we are seeing much more commonly. So one of them is called thermal ablation, and essentially what we do in collaboration with the radiologist is we stick needles into the tumor and we heat the tumor up really hot, or we cool it down very cold. One is called radiofrequency ablation. The other one is called cryoablation. But essentially what we try to do with that is we put a probe in, and just where the tip of that probe is, it generates energy. And if the tumor is round and small, we can insert a probe in there and heat it or cool it. It's still somewhat experimental, but in patients who are quite ill or elderly, who may not tolerate a surgery very well, sometimes that's a really good option to do these. Or in a patient who's already had multiple surgeries on their kidney, where the risk of losing the kidney or complications from the kidney are quite high, we will choose to put these probes in and just freeze the tumor or heat up the tumor. So thermal ablation or cryoablation, radiofrequency ablation, is being done more commonly as the technology advances. This can be done almost as an outpatient, so there's obvious nice advantages to the patient. But these procedures are not all without risk themselves, so they're really done in very well selected patients. The other thing I wanted to talk about is active surveillance. And what we do know with small tumors is that many of them grow quite slowly and will never spread. So if we see somebody who has one of these small tumors, often we will choose not to treat them. In fact, just to watch them, because at very small sizes, they're unlikely to affect the health of that person. So again, the physician that you see would likely talk about all of these options and why surveillance or treatment, usually with surgery or ablation, is the best thing for you. But many people, surveillance is a very good option and the best option for them. We are getting more experience in Canada. In fact, we are among the leaders of doing this surveillance, where we will watch the tumor to make sure it's not growing over time, with the intent, if it was ever changing, then we would obviously remove them at that time. So I just wanted to conclude, to go back to this, this lady. A few things that I want to explain is that with this case is that renal cell carcinoma really can affect anybody, male, female, very young to very old. Nobody is really immune to it. Unfortunately, we can't find people to screen based on risk factors because we're all at risk, really, except for people who have genetic syndromes. Screening is actually something that doesn't work, unfortunately, or we don't have the appropriate test yet. So again, just to remind you, she had a fairly large tumor, 35 years old, very healthy woman. She did have a radical nephrectomy because in her situation, most of the kidney was taken up by the tumor. She's now 3 years after surgery, and this is obviously the outcome that we want, and there's no signs of cancer recurring. She's back to life as normal. That's obviously the goal that we want for everybody. But as we know, this cancer does tend to spread to other parts of the body, and these are some of the common sites that this cancer will go to the other kidney, to the liver, to the bones, to the lungs, to the brain. And Dr. Rayom is going to talk about the treatment options that we have and all of the exciting things that have come over the last 10 years or so for patients who unfortunately have spread their disease. So if you don't have any other questions, that's all I wanted to say. Is there a question?
I just had a quick question on the surveillance you would do post-surgery.
Yeah.
What you would recommend and how individualized that is?
It's very individualized, and so that surveillance is based on, after surgery, we obviously look at the tumor under a microscope and we get a pathology report. And that gives us a lot of information about what are the chances that the tumor or the cancer spread before we removed it. So based on that, we'll dictate how frequently and how intensive the follow-up is. In some of these smaller renal tumors, the cure rate is almost 100% after it's removed. So that's really nice for the patient because it means they don't need very many imaging, through the years. Some people have very large tumors where we know the risk of it coming back, even though we can't see it, is almost 100%. And in those situations, we would be getting repeat CT scans or CAT scans, other forms of imaging, blood work, stuff like that on a pretty regular basis. So it really depends on...
What do you consider large?
Well, so it's not only the size, it's also the stage, it's also the grade of the tumor, and there are a number of nomograms and algorithms that we look at. So when I remove a kidney tumor, I'll put it on that algorithm, and based on that, I'll know the chance of it coming back and how frequently I should be checking for recurrences or things like that. So it's a little bit more complicated. So some 10-centimeter tumors are actually at a fairly low risk of coming back. Some 5-centimeter tumors at a very high risk for coming back. So it depends on the grade and stage and other factors.
Okay, I was just curious because I went from 2006 having a completely negative CAT scan to 2012 having an 8.5-centimeter tumor. So.
Yeah, so,
I was just curious.
yeah, and so they can quickly or they can very slowly. You know, I have a number of people who are over 20 years from their original surgery where it comes back. So kidney cancer is one of these things, and sometimes with treatment, they can go another 20 years, you know, so it is a very difficult one to figure out compared to some of the other cancers where after you go 3 years, you're in the clear, it's never going to come back. Kidney, unfortunately, is not one of those. Any other questions?
In the case of Hammer, you mentioned that the lady had a right abdominal pain, but the cancer was in the left kidney. I had the same situation.
Yeah.
Is there significance?
Yeah.
Lower right side?
Okay, I'm going to repeat that question, and then I'll repeat because I guess some people on the webcast probably can't hear what the question was. So this question was, the patient that in the example that I gave had right pain, but then on the ultrasound had a left kidney tumor. And basically the pain that that person was experiencing had nothing to do with the kidney tumor. So we call it incidentally found, meaning you weren't imaging trying to look for it, but just happened to have the ultrasound and just happened to notice it. You know, kidney tumor, total coincidence. Yeah, and this patient, this person who's here had the same experience. It's very common, extremely common. Someone gets a CAT scan for appendicitis, and then the kidney tumor is found by, you know, lucky or unlucky, depending on how you want to look at it, detection. The first question that was asked was, how can you tell how frequently you should follow somebody after they have surgery for kidney cancer? You know, is it 3 months, is it 6 months, is it every year, is it for 5 years, 10 years? And the answer to that is, if you didn't hear it, was it really depends on what the tumor looked like. But even with our best algorithms and our best guesses as to when we should do it, kidney cancer is very erratic in terms of its behavior and is not as predictable as some of the other cancers that we treat.
And would you do scans, ultrasounds?
The next question,
Combination?
yeah. The next question is, what do you do? Do you do ultrasounds or CT scans or MRIs? It depends. Again, you know, if someone is very young, we want to be careful with how much radiation we give. So in some cases, we may intersperse ultrasounds with CT scans or MRIs, things like that. In some cases, we only do CT scans. Others, we only have to do ultrasounds. So again, it depends on our level of suspicion for there being a recurrence. And if the suspicion is really high, we often do more intensive and frequent types of investigations. If our level of suspicion is really low, then we don't have to do as much. Yes?
For the post-operative scanning then, is it commonly done for all of the possible sites, or does that depend on?
No. So the question was, do you check everywhere? So if cancer comes back maybe in the bones, brain, lung, liver, do you scan all of these areas? And we don't. One of the main reasons is that the vast majority of recurrences will occur in the chest, so in the lungs, in the abdomen and pelvis. So those are the areas that we will typically survey. While these tumors do go to other parts of the bones and the brain, they typically don't occur there in isolation, meaning something would be detected, let's say in the lungs, and then we would investigate other areas depending on if the patient's having symptoms. So typically we would follow the chest or the lungs as well as the abdomen and pelvis. That could be with plain x-rays, with ultrasounds, or with CT scans. Those would be the typical investigations that we would use. If we have suspicion for other things, we may do other things like bone scans, brain imaging, things like that, but usually we need to have a suspicion for it.
What is suspicion like pain?
Yeah, so the question was, how do you suspect it? So yeah, absolutely. So for brain, for example, if it was, you know, really significant confusion, neurologic symptoms, you thought you had a stroke, you know, very severe headaches. In the bones, it's usually very severe bone pain that's clearly new, not something that's normal. So if somebody had very high risk and said they had a really significant pain in their arm that never was there, they didn't injure it, obviously we're going to be investigating that with scans or x-rays. Yes?
Is there an average size or like length of time that the tumor would grow before it metastasizes?
Yeah, good question. So the question was, is there amount of time or size or some predictor before you know that it's at risk of spreading? So size is a very important one. Typically, tumors less than 3 centimeters in size will not spread. Now, never say never, but it's very, very rare. And we know that from people who have genetic syndromes, well, they'll have, many, many tumors in their kidney, but we'll wait until one of those tumors gets greater than 3 centimeters, because then the risk of it spreading becomes a little bit higher. But the larger it is, the higher the risk. So a 10-centimeter tumor is at higher risk than a 5-centimeter tumor, but there's no absolutes. They're just, the length of time, we don't know. So some people will have tumors in their kidneys for many, many years, decades even, and it never spreads. Others could have a totally normal scan and then 1 year later have another scan for another reason, and they see that there's a tumor there that's already spread. So we're really not sure, and it's from patient to patient, it will be different. Anything else? If you have any other questions, you'll also have another opportunity after Dr. Rayom has had a chance to speak. Okay.